We like to invite back Dr. Leong Nam, the infectious disease specialist, to moderate our Q&A session with our three speakers. So once again, let's welcome Dr. Wee, Dr. Hia, as well as Dr. Chua.
Thank you. I thought we had another great session earlier on, and we touched on quite a few things from neurology to kids and vaccinations to even supplements, and finally about long COVID. Okay, we do have questions coming in, and you see this, which I'm holding it. The questions which you post in comes into me, and you get voted in terms of popularity. And I'm going to let Dr. Elaine have a rest first. I'm going to jump straight, okay, to our neurologist, improving memory fog. Okay, I mean, as you all know, I had SARS before. I was trying to use your site and say, my wife, I forgot this and that. It's because of SARS. But she's going to tell me, is there anything I can take to help me improve my memory fog?
Now, Dr. Leong, you don't have memory fog. If you forget your wife's anniversary, it's not because of SARS. Anyway, memory fog is an interesting thing. Now, scientifically, we don't really know what causes memory fog at the moment. It's still a topic of intense research. Although there is some suggestions that this is all immunologically related, and I showed you guys a preprint article that suggests that post-vaccination after a COVID infection, some patients do improve. There is still no proven therapy. Now, so I will hesitate to say that there is treatment, but perhaps symptomatically there are things that we can do for a patient who has memory fog. There are multiple devices now we can use in lieu of the memory these days. For example, memoirs, notepads, or these days handphones that we use regularly to remind ourselves of tasks that we have to fulfill, including our wife's anniversary and birthday, and many other modern tools we have to help us with all those things. But other cognitive impairments with long-term COVID, for example, executive planning, these are a lot more difficult to treat, but I think there is hope on the horizon, namely in a few ways. Firstly, there's a lot of research going on. Secondly, if you were to follow the blogs of those who have long-term COVID symptoms, many of them do report as time goes by that there is significant improvement in their symptoms. And so while we await the discovery of new treatments, there is hope in the air. Hang tight. And if you do need further help, to see a neurologist. We will try to see if there are other supportive therapies we can do to help you. So back to you, Dr. Leong.
Okay, just a quick, do you think a 1 minute answer, slight dementia after COVID, is there anything you can do for that?
So dementia is not actually an illness. Dementia is a syndrome that is usually caused by various underlying conditions. For example, Alzheimer's disease or vascular dementia being the most common. Now, if you have dementia after COVID, then I wonder, are you truly demented, or is this just a post-COVID cognitive sequelae? And I would definitely hesitate to label a person as having dementia right after they have a COVID infection. So I think this is something that my colleagues in neurology are well aware of, and we'll be taking suitable cautions before we give a patient such a label or diagnosis.
Okay, I'm going to ask Dr. Chua here. The one of the questions was, what about long COVID in children? Do you think you can give us a short summary on it?
I think I will have to defer to my pediatrician colleagues.
Okay, yeah. So what happens is that in long COVID in children, the symptoms are a little bit different from adults. So what happens is that they do have the fatigue, they do have a little bit of myalgia, tiredness, but they also have some of them report persistent runny nose. So these symptoms tend to go away on their own after about 12 weeks, and most children fully recover. And for those children who have developed multisystemic inflammatory syndrome in children, they found that actually post-COVID, when they've done the MRI for the children, their hearts are actually quite pristine. So again, I think children are relatively spared even if they've developed COVID-19.
Okay. I have the permission of the two chairs of CME committees to not deal with just the safe questions. And so one of the questions I'm going to follow up with Dr. Cindy here is this. The 5 to 11 years old, they have actually very mild illnesses. then should we actually encourage vaccination? And the caveat is this: at this point in time, children vaccination less than 12 years old have not been approved. Not approved. We're talking about a non-approved situation, but we expect it to be approved shortly, just like the States. What's your take on it, given that 5 to 11 is actually quite mild?
Okay, so a few things we have to consider. One of them is that we have to look at it from two different points of view. One is that if we look at it as a physician, or whether we look at it as an epidemiologist. If you're an epidemiologist and your primary concern is to look at the population and the health of the population, your deductions after all the data has been presented may be quite different from a physician. As a physician, I'm sitting in front of the patient, and the patient's mother is asking me, should I take the vaccine or not? My answer may be very different compared to the Minister of Health, right? So I think we have to also strike a balance. The thing is that in children 5 to 11, the disease is very rare. 50% have no symptoms, 50% have mild symptoms. Only 1% require hospitalization. And the hospitalization for this 1% is actually due to sometimes bronchitis, pneumonia, gastroenteritis, and dehydration, and very rarely a handful of cases from multisystemic inflammatory syndrome in children. So I think we have to take that into balance. Now, the 5 to 11-year-olds are receiving a different vaccine, and so they are receiving 10 micrograms of the mRNA vaccine with a different buffer. It remains to be seen what is the effect downstream, so I really am not able to give you a direct answer. But we have to weigh the pros and cons at that point in time. And also we have to take into consideration what is happening in the environment at that point in time. Is it a variant that is deadly, or is it a variant that is mild? If it's a variant that is deadly, then I suppose it makes sense to vaccinate. But if it's a variant that is very mild and the children are overcoming this disease, then we have to think twice about it. So there's no straight answer to this, but I'm just giving you some thoughts that may help parents make their decision, or physicians make their decision for the patients.
Yep.
May I
Yes,
heighten the
please.
gentleman, Dr. Leong, with your permission?
Yes, please.
Sorry, Dr. Leong and I have been friends for many years, so we are
Yeah.
a bit less formal. But Dr. so now I'm a parent now, I'm not a doctor, and I just had to cop a free consult from you. Sorry, so I was wondering, because before this thing came out, I was very worried that one of my sons, I've got 3 kids, might catch COVID, because he has got status aspergicus. And he was admitted to the ICU once before and very nearly required intubation. So I was thinking, if the vaccine ever was approved and was proven to be safe, then my son with a pre-existing respiratory condition might be a person I might take special care for to consider for this sort of vaccination.
Yes.
Would there be other children with a similar risk factor that you would
So
think?
in NHS in the UK, the guidelines are quite balanced. So before they actually rolled up fully vaccination for 12 years and above, the guideline was actually children who with significant comorbidity, children who are in homes and who are at risk of developing severe COVID infection should actually take the vaccination. Whereas those who are relatively well and would come out relatively unscathed from COVID, then maybe we should think about whether or not to vaccinate. So I think this is a very balanced view.
I agree. Okay, I'm going to jump in here and say a few things. And one of the reasons why I asked Cindy about what is long COVID in children is that there are studies to say that long COVID exists in children. We're talking about risk of between 10 to 40%. So do you then go for mild illness, or do you end up with long COVID, or do you end up with a potential complication of the COVID vaccine? And so far, the COVID vaccine risk for the children is actually extremely low. And yesterday, my heart sank. My heart sank for one reason, because an infant died of COVID-19. This is a disease which is supposed to be mild for children, but when it happens to your own child, the statistics don't count anymore. The statistics don't count because it hits right at home. So coming back then, who will die? Who will benefit from a COVID infection? Who will benefit from the COVID vaccine? At the end of the day, it's a little bit of a roll of the dice, because we don't know and there are no predictors. Now, the good thing for Singapore, and this is what I always say, is number one, we are not the first few countries to do vaccinations for children. The US are ahead of us. They've at least, at the last count, there were 3 to 4 million children who had gone through it. And in time, we're going to see data coming out to see the safety and efficacy of the 5 to 11. Number two, with that, we can then compare against the risk benefits of the vaccines versus risk benefit of the illness. And indeed, I think Cindy's really hit the nail on the spot by saying, what about Omicron? If Omicron comes out to be really harmless for children, and we don't see the neurological complications or the cardiovascular complications, and we hardly see any MISC, and we have no data on MISC in children for Omicron, then do we need a vaccination? So it is a big unknown. Okay, so for the listeners, for the viewers now, my suggestion is this. Number one, you don't need to make a decision now, especially in Singapore, there's no approval for it. But watch this space, watch the data. As the data comes in, you get to see clarity, granularity on how good the vaccine is, what are the problems, and in fact, things change. You get Omicron. Will there be another Optimus Prime that would destroy Omicron? There may be. And when that comes along, there may not be an issue anymore. And so that comes much later. I'm not going to let go of Cindy yet, okay? I'm going to ask her one question. Okay, I'm going to push her back 2 years later. 2 years later, let's say the vaccine is approved, it's found to be safe for 5 to 11, in fact, 6 months and above. Do you see this vaccine coming into play as part of the childhood vaccination prevention program? Okay, this is 2 years later when we have good safety data. Do you see that happening?
So I'm going to throw the net a bit wider in the sense that this may not be the only vaccine that is approved 2 years down the road, because we have other types of vaccine, whole cell vaccines, subunit vaccines, other things that come into play. So I think we have to look at the data accordingly then. But at that point in time also, as I come back to my point again, what is the disease severity in the community? And then apart from the disease severity, what is the burden on the community? How many days off work the mother is going to have, or how many days off school the child is going to have? This needs to be taken into consideration as well. And then lastly, is this virus still going to keep mutating? If this virus is still going to keep mutating, are we going to keep up with it? Do we need booster after booster after booster? So I think these tend to be must be taken into consideration. Now, childhood immunizations, we are talking about things like measles, very stable, rubella, very stable. Yeah, so diphtheria, tetanus, pertussis, bacteria, very stable. We're not having these crazy mutating viruses, and I think that actually makes me think about whether or not it should be part of the childhood immunization. Maybe there is a vaccine that can actually give some partial protection against this cold, and then maybe reduce the severity, something like a rotavirus vaccine, where you have many strains and you may not stop every strain from occurring in the child, but the disease severity is reduced such that mortality, morbidity is all down. So I think if that is the situation at that point in time, I think yes, we should consider that as part of the childhood immunization program. I hope it's a fair answer.
I think it's a very fair answer. In fact, I'm very sure HSA as well as the Ethics Committee on Vaccination will go through the same questions, and I agree with her. My take is that eventually I don't think it will happen. Why? You see, there are 4 other coronaviruses that were there, there are actually 5 or more. 5 or more coronaviruses that are there even before the occurrence of SARS 2003. So what it means is we actually have been living with coronaviruses all this time. So for all you know, it becomes a common cold, you get a runny nose, and that's the end of it. Okay, again, I'm not going to make this a safe paddle discussion. I'm going to jump to the neurologist, the one who's really smart. If I was smart, I'd become a neurologist. And what the question is this: we have people who had reports of strokes after vaccination. Can you share with us what's your take on it?
Well, firstly, the smart one here is Dr. Leong. Now, how do you put it? Now, strokes after vaccination. Yes, I've heard of stories of people having strokes after vaccination. Now, whether vaccines are a risk factor for people developing strokes remains to be known. We await data from countries around the world and our own epidemiological data. One of the problems we have about knowing whether an agent or intervention is a causative factor in the disease occurrence is this, that how much above the baseline rate does that intervention raise the frequency of the disease. Now, stroke occurs in about 8,000 patients a year in Singapore, and about 1 in 5 people are expected to have a stroke in their lifetime. So that's a pretty high frequency event, and it's very hard for us to detect increased signal so quickly. But be that as may be, even if the vaccine does, and that's just me conjecturing, even the vaccine does increase the risk of stroke, the fact that we haven't heard much about it, the data doesn't prove it, means that even if it does increase the risk of a person getting a stroke, it must be really very small. Now, to that end, I think we should look to our National Registry of Diseases, of which I know Dr. Ramani, who's in the audience right now, is helped to organize, and he's still helping to look at the data from. We await the NDRO to tell us the latest data to see whether we have a signal for increased incidence of stroke in these few years that we are rolling out the vaccine. Now, we discussed the theoretical basis just now, Dr. Leong and I, about on why a vaccine could potentially lead to a person having a stroke. Now the coagulation pathway in the body is always balanced between thrombosis and anticoagulation. Now we know that the reason why, or rather the theoretical reason why a person might have increased risk of stroke in the peri-operative period is because there's a relative pro-inflammatory state, which is pro-thrombotic. So if I were to conjecture, if it's really true that the vaccine does cause increased risk of stroke, then it might be because it provokes a relative pro-inflammatory state in the body right after administration, and that might somehow increase the risk of a person developing arterial thrombosis. Of course, that's not proven, that's just conjectures, and that should not be taken as a contraindication to a person getting the vaccination.
I would agree with you on that, Wickham. In addition, I really like the idea of a pro-inflammatory state. Let's be very frank. The vaccine actually kind of stimulates your immune system, and when that happens, you have a pro-inflammatory state because all your cells are activated. But the same thing happens as well, if not worse, when you have an infection. When you have an infection, your whole body is stimulated, you have pro-inflammatory state, and we have already learned that you could actually have thrombotic phenomenon happening. So the other way of looking at it is, with the infection, you're going to get strokes. With the vaccines, you perhaps may get strokes. I'm using the word perhaps because there's no evidence for it, or if there is, the numbers are actually very, very small. So the person is going to get it with the infection or with the vaccine, but with the vaccine, the risk is possibly much lower. Okay, so at this point in time, despite this anecdotal experience, individuals reporting them, I'm still going to vote for a yes for vaccines, even with this potential risk of strokes. Okay,
so
not proven. On the stress, it's not proven.
No, not proven. Anecdotal reports from colleagues saying that they see patients getting strokes after vaccination, but it's not proven. It could be just plain bad luck, so we don't really know.
Yes, I mean, we've seen it in movies where it's like, what did you do to me and my family? And the guy suffers a heart attack. It's like, you see the stress of it all. Perhaps this event is giving me a heart attack. Okay. I'm going to jump on next to Cindy here. COVID, influenza, I mean, we're living in COVID. How can you differentiate COVID and influenza? From history to testing? What else?
Okay, yeah, so I'm just going to focus on children because I see mainly kids. I've not seen an adult patient in 20 over years. Okay, so basically what happens is that in influenza, the fever tends to spike really high in children. They really come down with a bad very bad myalgia, they're knocked out. If you talk to the parents, they'll say, my child's very lethargic, he's sleeping, he's tired. So that's one of the hallmark of influenza. And also they tend to have sore throat and all. But in COVID, the kids tend to be quite well. And the scary part of it is that they look like any other cough, cold, runny nose. Okay, how do you know whether there's a sense of smell is lost or not? Sometimes the young children are not able to tell you. So this is the other thing that sometimes may help us, but the older children might be able to tell us. And also the other thing that's maybe a bit difficult to differentiate between between influenza and COVID is that both of them can have a little bit of gastroenteritis symptoms. So I think mainly the fever and the severity of the illness really does help, to help differentiate the two.
Okay, we're going to down to the last 1 minute. Okay, I'm going to ask Dr. Chua. The top question is, are we seeing difference in the long COVID symptoms demographically in different regions? Do you want to have a try at that?
Okay, I will attempt, but the information I got from BMJ review article actually cited more than 60,000 articles written on long COVID, of which they took 200 over and synthesized it into the review article. So we're talking about a huge number of data, and a lot of the studies are pre-print or still in review state. So I think we have to take that into account when we look at it, whether the self-reported symptoms. But the general trend is that fatigue is one of the top reported symptom, and then followed by a third of them being cardiorespiratory, and then 20 to 30% neuropsychiatric symptoms. I think in the NCID experience, they also reported fatigue as well as dyspnea, residual shortness of breath, as one of the most common symptoms.
Okay, great. I think that's a nice short summary. This is an evolving field, so watch this space. I'm going to do the last question here. Hong Kong and mainland China seem to not have a late surge of cases in COVID-19 compared to countries using mRNA. This is not a comparison between inactivated vaccines versus mRNA vaccines. No, it is a comparison between strategies. Is it a zero tolerance strategy, or is it a case where living with COVID? The rest of the world, except for 2 places, have gone on with living with COVID. And we all know it. When you live with COVID, you're going to be exposed to it. You're going to have huge cases. And we saw that in Singapore, and we moved into it somewhere in May and June this year. Now, Hong Kong and mainland China, if you try to go into that country now, my friend, you're going to you have a 21 days quarantine. I was speaking to one of the nice sisters in the ward, and they tell me that if I want to go home, I have to be quarantined for a total of 56 days. If you were to go for this sort of scenarios, all kinds of viruses would have lived in you, actually went on a holiday, come back, died in you, and then buried or incinerated by the time you leave 56 days. So there's no way the virus can actually enter. But wait, the virus still entered. At the coastal regions, you actually have COVID cases in China. And when this happens, there's a lot, lockdowns. Fellow Parkway Yanshins, fellow doctors, do you want another lockdown? I'm voting against it. I'm voting living with COVID and just getting on with life. Okay, so that will address the question why mainland China and Hong Kong doesn't have COVID. It's about strategies. It's not about vaccines. And certainly no politics involved. Okay, with that, I'm going to end this session. I think it was a great, exciting session. I want to thank all the speakers, the 4 speakers here again, as well as the 3 speakers here, as well as the 3 speakers earlier on. I think it was an exciting Saturday afternoon. And as usual, a Saturday afternoon, I can think of 99 different things to do, but you chose to spend it with us for learning on COVID-19. And for that, I think you have my vote. You are my champion. Thank you very much, doctors. Thank you.